I think as you already know, I had already discussed about the differences between the diarrhea, dysentery and the causative agent. So let us go about the uh, laboratory diagnosis. First of all, if you recall, these are the causes of dysentery and they have some specific virulence factors. Among them, if you see, the inoculum size of Shigella, Entamoeba and Giardia is important. A particular inoculum size causes the infection, otherwise it cannot cause infections. For some of the organisms like cholera or enteropathogenic E.coli, specific factors help them to adhere and then production of the toxins. So these are all the virulence factors which are associated. Then I had already classified into three types. One is called as non-invasive, the other will be invasive, and the other part would be whether it's inflammatory or non-inflammatory. When it's non-inflammatory, we end up getting what we call as diarrhea. When it's inflammatory, we call it as dysentery. And some of the pathogens can also invade from the mucous membrane into the bloodstream. Then we call it as invasive disease. Moving on, among the diarrhea dysentery presentation, as you can see, the presentation can be in various forms based on the patient profile. The first patient profile would be a case of food poisoning, especially when a few people will have similar complaint of either diarrhea or dysentery, and will have a history of eating at a common place, maybe at a function or a common site or a common restaurant, etc. That would be classified as a case of food poisoning. Similarly, in some particular patients, like patients living with HIV infection or in advanced case of AIDS, we have some specific particular organisms which have more propensity to cause diarrhea. For example, Cryptosporidium, Cystoisospora, Microspora, etc. Similarly, we have the entity known as called as the traveler's diarrhea, which have some specific organisms I already discussed yesterday. Now, coming back to the laboratory diagnosis, as you know, diarrhea is very common. Most of the time, diagnosis is not required. It's a self-limiting disease. Most of the cases that we will encounter will belong to either cases of food poisoning or cases of isolated food poisoning or cases of traveler's diarrhea. Because it is predominantly self-limiting, most of the time the patient will not seek treatment and it is not required to treat. Only consideration that has to be kept in mind whether the patient is dehydrated or not in acute case scenario. For that, we only have to manage the dehydration of these patients. The question remains, so in which category of patients you need to seek for proper diagnosis? That is very important. First, look for the patient category. If there is a large outbreak of food poisoning in certain scenarios, like a function or in school or in daycare centers for children, if that is the case scenario, then it has to be investigated. In your PSM classes, I think you have already heard about something called as outbreak investigation, right? So whenever there is an outbreak, this category falls into the outbreak investigation. Other than that, specific patient profile, like if the patient has some sort of immune compromise, you have to investigate thoroughly, because you will end up encountering some of the organisms which are not commonly seen. The next category of the patient which you will encounter more frequently are the patients complaining of dysentery, that is watery diarrhea along with blood in stool with tenesmus. Now, why this is important? Because some of the invading organisms may cause invasive disease. The target is not only to prevent the disease process but also to stop the progression of the disease. So, how can we detect this? The best sample would be, what would be the sample for diagnosis? You have to collect the stool sample. Now, how will you collect the stool sample? That is very important. Any idea? Okay. Now look at this. There can be two samples, either freshly passed stool sample, and if not possible, take a rectal swab. do not collect uh, stool that has been passed for a prolonged period of time, because it will eventually get contaminated. Furthermore, you have to collect directly into the stool container. You cannot take the sample for, say, a bedpan or etc. So you cannot take a contaminated sample. Furthermore, if I have already explained in last class, if some sort of delay is expected, you need to send in a transport medium. When to collect? When the patient is having diarrhea, as soon as the onset of the disease is possible, and obviously before any kind of antibiotic. Now, this is an ideal case scenario, but it is highly unlikely that you will be able to get this kind of sample. Nevertheless, what you need to keep in mind is first point, that is, you should advise the patient to collect the stool sample in a clean container. It may not be sterile. Okay. For example, if you remember, when you advise a patient for an urine culture, you advise for a sterile urine container. But as far as the stool is concerned, you did not need to have a sterile container. However, it should be clean container. And more importantly, it should not be clean with any sort of disinfectant like that. Because if those disinfectants are present, then most probably the organism will die and you won't be able to recover the organism. Next would be, I have already told you, you cannot collect from, say, bedpan. Sometimes the patient may defecate on the bed itself. You cannot collect it from the bed sheet or etc. Next, unpreserved stool, or whatever happens, you have to get the stool into the laboratory for processing under 2 hours. If not possible, you have to look for preservation of stool sample. Another alternative, I already sometimes, whenever you advise the patient to collect the stool sample, in these sort of conditions, it is not possible to collect the stool sample. Alternatively, we can advise to get a rectal swab. Now, how to collect the rectal swab is, you need to take the cotton swab along with the transport media, put the swab into the anal canal, push it about 1 to 2 inches inside so that the tip of the swab reaches into the rectum. Remember, it's not an anal swab, it's a rectal swab. Keep it for about 2 to 3 minutes, and then this is the picture where in a test tube or a container which have a carry-player media and the swab stick in which you can collect the sample and send for stool sample. Now, as previously in cases of diarrhea, what would be the investigation? First would be the macroscopic examination. Under macroscopic examination, we'll look for first the gross appearance, what is the color and what is the consistency of the stool. Obviously, if the stool sample is formed stool, that means that is no diarrhea. You don't really need to investigate until and unless the patient is having any parasitic infection like roundworm, tapeworm, etc. The only considered stool sample would be either semi-formed stool or liquid stool. Then we have to assess whether the stool has any blood streaks or not, or whether it's a overtly bloody diarrhea, or whether their mucus is present or not. Next would be, we have to look for any kind of parasites which can be seen macroscopically, like in last class I have already told you. Then we come to the microscopic examination. Under microscopic examination, this is a picture which shows the normal findings of a stool. That means the findings which you will encounter normally. What does this compile of? First, you can see there are some fibrous structures. These are the muscle fibers, connective tissues, various epithelial cells. Sometimes leukocytes may be seen, and a lot of vegetative matter like plant cells, pollens. These can also be seen, and sometimes some specific crystals can be seen like this. It is called as the Charcot Leiden crystal, which can also be seen sometimes in cases of eosinophilia or in even parasitic infections which raises eosinophils. I think you have read about Charcot Leiden crystals which are found in the sputum. Those are swallowed and can also be seen in the stool. Normally, you may find very few pustules or leukocytes, but huge number of leukocytes can indicate either of these infections. These would include Campylobacteriosis, Shigellosis, or E.coli, enteroinvasive or enterohemorrhagic. If the number of pustules are there are a lot of pustules, then you have to consider this diagnosis. Okay. However, look over here. In case of enterotoxigenic and pathogenic E. coli infections, pustules are not seen. So, in the microscopic examination, presence or absence of pustules will help you to delineate between the causative organisms. Okay. Now, what does pustules look like? Now, this is the picture. I think you can see these are the agglomerations of the pustules that can be seen on either a saline mount or an iodine mount prepared. And I think you can also see red blood cells which indicate presence of blood. Sometimes the blood may not be seen macroscopically, but under microscopy you can observe the red blood cells. Many a times, if the bleeding is much more or presence of blood is more, you can also find rouleau formation of RBCs in the stool. So these are very important findings that has to be reported and corroborated when you are assessing the patient clinically. Now let us look at some of the other findings. Can you decipher what this picture shows? You have already seen pustules, right? What is this? Now this is not a pustule. This is the trophozoite of Entamoeba histolytica. Now keep in mind, this trophozoite form you can see only in freshly passed liquid stool, not in semi-form, obviously not in form stool, and freshly passed, because as the time goes on the trophozoite will die. The trophozoite will show motility and sometimes it may be confused with pustules, agglomeration of pustules. However, if we look carefully, we can see, like over here, it's a methylene blue stain in which the trophozoite has taken up the methylene blue stain. And the picture above, if you can see, there is a trophozoite. Can you see over here? This is the trophozoite in saline mount. Similarly, in iodine and saline mount, you can see circular structure. These are the cysts of Entamoeba histolytica. So the diagnosis of Entamoeba histolytica infection can be readily made just by microscopic examination of the freshly passed stool. Then Entamoeba histolytica causes amoebic dysentery. I think you have already read about the differences between bacillary dysentery and amoebic dysentery. Now, in case of bacillary dysentery, you have to look for certain indications. Why? Because there are a lot of number of bacilli normally present in the stool. Very good indication would be presence of motile structures. The first motile structure is, look at the picture right above. It shows the sluggish motility of E. coli. Now this E. coli is normally present. It will give you no indication whatsoever. But over here, look at this, the second picture. I think you can see some of the bacilli are moving very rapidly, almost so rapidly that it is very difficult to focus on it. Can you see? So this is the type of the motility that can be seen in case of cholera infection, and this type of motility is called as darting motility, almost as if a dart is passing through. Okay. So if it is a watery stool and you can observe this darting motility, high probability this is a case of cholera. Now let us look at this one. Whatever it is, it appears as if like a leaf that is falling from the trees in autumn. This is called as falling leaf motility, and this is seen in case of Giardiasis. And finally, I have already told you the trophozoite of Entamoeba histolytica, and in freshly passed stool, it will show slow but sluggish movements. Remember, this kind of movements will not be seen in case of pus cells. So this is an actively motile trophozoite. Okay. Now, after having compiled the microscopic report, next we need to go for definitive diagnosis. Then we can go for culture. So what are the media that we will use for culture? First of all, we'll use a MacConkey agar. Then we'll use a, what is this? This is the TCBS, and this is an XLD agar. And over here is a special type of MacConkey agar called as Sorbitol MacConkey agar. Okay. Now, why this is important? Because there is a variant of E.coli called as O157. This variant of E.coli is capable of causing dysentery. Now, this E.coli will not ferment sorbitol. Normally, what happens? The MacConkey agar shows E.coli as lactose fermenting or pink colored colony. Now, sorbitol MacConkey agar, this variant will not show the fermentation. Hence, we can isolate this particular strain by using sorbitol MacConkey agar. Okay. This is the growth of Shigella species on XLD agar. Okay. If we do observe this kind of colony, then we have to identify. How to identify? First, we'll look at the Shigella is a non-lactose fermenter, right? So on MacConkey agar, there will be colorless colonies, and also on XLD agar, we will get a red or colorless colony, by which we have to confirm with a biochemical test. Now, Shigella is a non-motile species, and then we have to go for what is called as serological testing. Now, keep in mind, this serological testing has got no relation with the serology of human body. This is the anti-sera. Anti-sera will react with particular antigens of Shigella, and if the reaction is positive, then we can identify this to be as Shigella. Okay. So, specific Shigella anti-sera can be used for identification of Shigella, including the species of Shigella. After that, because Shigella causes shigellosis and invasive disease, you need to give antimicrobial therapy. For that, you obviously have to put up antimicrobial susceptibility testing. Based on the report, you either have to change the antibiotic that was given empirically or continue them, whatever the case may be. Now look at all this picture. On TCBS agar, you can see this yellow colored colonies. These type of colonies are seen in case of Vibrio cholerae. Now Vibrio is also oxidase positive. So by these two tests, we can identify Vibrio cholerae. Furthermore, we can go for direct identification with Vibrio serology. I think you have already learned about the O1, O139. There are specific anti-sera by which we can identify the specific species and strain. Now, another substrains would be Ogawa, Inaba, and Hikojima. Each have specific anti-sera. You can test for those anti-sera and identify. Finally, again, in mild cases of cholera, antimicrobial therapy is not required. But if the patient is severe with severe dehydration, antimicrobial therapy may be required. For that reason, you have to put up antimicrobials. Finally, as you can see, on Sorbitol MacConkey agar, we can find this type of colonies. This would indicate probably this is E.coli O157. Again, we can go for the biochemical testing and anti-sera testing for identification and list. So the methodology is almost pretty much similar. Based on the type of the colonies seen on the specific agars and confirmation with anti-sera testing, we can identify, followed by antimicrobial susceptibility testing. Identification can also be aided by various biochemical reactions. These can be done manually or by automatic method, whatever may be the method. Based on the biochemical result, you can also identify. So this is all about laboratory diagnosis of dysentery. All the diagnosis for parasitic infections can be identified by presence of either ovum, cyst or parasites in the stool. It is suspected, ideally at least 3 stool samples must be sent for microscopic examination, ideally on alternate days, because the excretion of either ovum or cyst from the organism is intermittent, it is not regular. So one single sample, if it comes negative, does not exclude the disease process. You need to have at least 3 reports, ideally on alternate days. Okay. So that would conclude about diarrhea and dysentery. Any questions? Now, in if your theoretical or practical examination, if you are asked how will you proceed for diagnosis in case of diarrhea and dysentery, I think you will be able to answer. So first you will need to differentiate between what diarrhea is and what dysentery is. And again, in diarrhea there will be acute and chronic based on the patient profile and the probable infective pathogens. For dysentery, the diagnosis or laboratory diagnosis becomes very much important because of use of antimicrobial therapy. You need to delineate the causes of diarrhea and the causes of dysentery according to the age group and according to the infecting pathogen. And for the laboratory diagnosis, most important part of the diagnosis would be examination of the stool. So for that we have to go for the gross, the microscopic examination, and for culture. When I say culture, that means culture for identification and susceptibility test. Okay, so that would conclude. Now, as for your laboratory diagnosis of infective pathogens, I think all are covered. Only for the hemoparasites, the filariasis and leishmaniasis, I will cover in the next week because there is a lecture that is pending. All other are covered, right? পড়ানো হয়েছে কি হয়নি? কি সিনড্রোম আছে বলো? কি syndrome হবে? একটা respiratory tract infections? You have to study like that, na? In respiratory tract infections, you have upper respiratory tract infections and lower respiratory tract infections. Then we have infections of the nervous system, predominantly the central nervous system. In central nervous system, we have most importantly meningitis, encephalitis and encephalopathy and other infections. So these two are most important. In case of cardiovascular system, what would be the pathogen syndromes? জোরে বলে শুনতে পাচ্ছি না। Acute rheumatic fever, okay, and there is infective endocarditis that you should read, and you have to read about the sepsis. These three are very important. There are many other infective syndromes also like pericarditis, etc., but these three are important. Okay. Another syndrome would be the STI syndrome. STI and RTA means reproductive tract infections. Okay. In the GI, we have two specific syndromes, the diarrhea and the dysentery. And then we have diagnosis of hemoparasites. I have already discussed about laboratory diagnosis of malaria. For filaria and leishmaniasis, we will cover in next day because, as I have already said, there is a lecture class pending. Other than that, we have to cover the healthcare associated infections and the antimicrobial stewardship program. Those will be covered after the lecture classes. Okay. Now, healthcare associated infections, I think this class has already been taken. So please do interact because it will be a long topic. What do you understand by healthcare associated infections? So any sort of infection which is observed in the healthcare settings can be called as healthcare associated infections. There were various terminologies used earlier like nosocomial infections or hospital acquired infections. Then appropriate term would be healthcare associated infections. Now, who are the people who are exposed to these sort of infections? Most importantly, the patients who are admitted or getting exposure to the healthcare settings, the people who are working in the healthcare settings like healthcare workers. So by that rule, everyone associated with healthcare can be affected directly or indirectly. Now, today we will discuss about the infections occurring in patients. Healthcare workers may be infected by various routes. The most common route would be by needle stick injury. Okay, so that's a separate topic that has already been taught, I think. Yes. As far as the patients are concerned, we have four major types of healthcare associated infections. Now, by definition, HAI or healthcare associated infection can be defined as an infection that is seen in a patient who has been admitted for at least 48 hours in the healthcare setting. This is to differentiate it from community acquired infections by which the patient may have already been infected and presenting after admission. Understood or not? Patient may be infected in the community, then the patient may become symptomatic and get admitted. Then we can easily say it's a community acquired infection. Many a time the patient may be infected, but the symptom starts after being admitted, say for any other cause. That is not an healthcare associated infection. That is also community acquired. That means what you actually understand by healthcare associated infections is that these sort of infections were not present in the patient's body at the time of admission. So the patient has acquired the infection from the setting itself. So this time period has been delineated as 48 hours. Okay. As I have already said, healthcare infection does not mean only for the patient, also for the healthcare workers. Why do these infections occur more commonly? The risk factor will depend on all the factors. All these factors will contribute, like the immune status of the patients, the hospital environment, the prevalent organisms in the hospital settings, how virulent they are, how resistant to drugs they are, then what are the specific type of interventions that are being performed in hospital, and then the poor hospital administration, that means the inability of the hospital administration to control the infections. These all can affect the total number of hospital healthcare associated infections. For example, say in a peripheral hospital where not many procedures are done, what would be the rate of HAIs? Obviously very low, because if the procedure is not done, the chances of patient getting infected are very low. Now take an example of a say tertiary care hospital with a huge ICUs. Most of the patients are moribund patients. A lot of interventions are done. The number of HAIs will be very high, even though that hospital has a robust infection control system, proper antibiotic policy, but still the rate of infection is high. So just one single parameter would not be able to give you the clear-cut picture. Now, what would be the sources of HAIs? Either it will come from the patient's own body, then we call it as the endogenous source, or from the environment, we call it as the exogenous source. Now, what are the environmental sources? It could be objects like any object that is present in the patient vicinity, even air, unfiltered air may cause many types of infections, or water, and very importantly, the hands of the healthcare workers. They will, if the hands are not clean, organism will be transmitted from one place to the other. And more importantly, look at the column in the right hand side. There are some specific pathogens which are very dangerous. This set of pathogens are also called as the escape pathogen. These include Enterococcus faecium, very commonly resistant to vancomycin, Staphylococcus aureus. I think you already know about the MRSA or methicillin resistant strain, sometimes also resistant to vancomycin. Then Klebsiella, Acinetobacter, Pseudomonas, and Enterobacter species. These 4 gram-negative organisms are very potent and they can be resistant to carbapenem group of drugs also, causing it leads to very difficulty in feeding the patient. So these all resistant drugs are clustered together and called as the escape pathogens. Other than these pathogens, other type of infections may also occur. Among them, that would be very commonly Mycobacterium tuberculosis. It may spread from one patient to other in the hospital itself, like coronaviruses, influenza viruses. These can also called healthcare associated infections. Coming to the mode of transmission, how these pathogens are transmitted. These are the 3 common modes of transmission. The first mode of transmission is contact transmission. The second would be airborne, and third would be droplet. Now you tell me, what is the difference between droplet and airborne transmission? The difference between airborne and droplet transmission. The primary difference, the most important difference, is the size of the particles. Droplet infection, those are caused by the particles which are size more than 5 micron. Hence, these can be arrested by the normal respiratory defense mechanism and also by using of mask, the commonly used mask. But airborne transmission is caused by particles less than 5 micron. In that case, normal mask will be inefficient. Furthermore, when you visit the hospital ward, you will see that the beds are placed at certain distance from each other. That is about close to 3 feet. That is the distance the droplet can travel from the patient's mouth or nose. By distance, you can prevent droplet infection, but airborne infection you cannot prevent by distance. In a room or in a hospital ward, if there is one patient who is infected with an airborne disease, all people will be infected. Does not matter whether difference is 6 meter or 10 meter. This would be important when we will be considering about the preventive measures that we can take for transmission of the diseases. Now, based on the type of the infections, these infections can be classified into predominantly 4 types. The first one is called as the catheter-associated urinary tract infections. The second one would be central line associated bloodstream infections. Then ventilator associated events, earlier called as ventilator associated pneumonia, now it is more commonly called as ventilator associated events, and surgical site infections. So these are the 4 predominant type of healthcare associated infections seen in patients. So let us look at these particular infections very briefly. The first one would be catheter-associated urinary tract infection. As the name suggests, that means a urinary tract infection which was not present in the patient when he or she was admitted, but the infection started after the patient was catheterized. So by that definition, any symptom of urinary tract infection, if present in the patient 48 hours after placement of the urinary catheter, it is called as catheter-associated urinary tract infection. Understood? A patient coming with urinary tract infection on admission is not catheter-associated, that is urinary tract infection. A patient coming with any other sort of ailment for which he or she was catheterized, and after catheterization 48 hours, if the patient present with any signs or symptoms of urinary tract infection, then we will call it as catheter-associated urinary tract infection. Understood? Okay. Technically, there is two classification even in catheter-associated UTI. The first would be catheter-associated bacteriuria. That means there is presence of bacteria. It may be symptomatic, it may be asymptomatic. If it is symptomatic, we call it as COTI, and if it is asymptomatic, we call it as asymptomatic bacteriuria. Catheter-associated asymptomatic bacteriuria. Why? Because generally we do not advocate for antimicrobial therapy in case of asymptomatic bacteria except in certain scenarios. Like if the patient is pregnant, if the patient is immune compromised, if the patient is undergoing any sort of urinary tract instrumentation or surgery, in this case scenario we will advocate for antimicrobial therapy. Otherwise, we will only advise for removal of the catheter itself. But if the patient is symptomatic, that means the infection has already started. Now you have to give antimicrobial therapy. Obviously, you have to remove the existing catheter, that is elementary, but you have to give antimicrobial therapy. So, for the sake of treatment, it can be divided into two parts. One is called as catheter-associated UTI, another would be catheter-associated asymptomatic bacteria. Now, from where does this infection comes? Now, look at this picture. So, when we are putting a catheter in the patient, we are putting the catheter over here, as you can see, and there is a ball which is filled with air, balloon, so that the catheter is retained within the urinary bladder. And then this catheter is connected, the outer end is connected with the drainage tube into a bag, also called as the urobag, which collects the urine. Now, how does the organism enters? Now, this is a closed system, right? The catheter is inside the bladder and the other end of the catheter is inside the urobag. So, ideally it's a closed system, so the organism cannot enter. So, how does the organism enters into the urinary tract? The first part would be, it could be from, suppose this is the catheter, there is an outer covering and there is an inner covering. If the infection is acquired through the inner, we call it as intraluminal, the lumen, intraluminal. And if it gains from outside, we call it as extraluminal. Now let us consider this fact. Now this is the urethra, right? That means it is covered with skin. So the urethral opening, there will be chances that organisms can enter on the outside of the catheter, of the extraluminal. When does this extraluminal insertion of organism occurs? At the time of inserting the catheter. If the external genital region is not properly cleaned, then organism can be introduced during placement of the catheter itself. Right? Any confusion about that? Then that is during insertion. Otherwise, if you break this closed system, the organism may travel from inside the lumen of the catheter, causing intraluminal infections. How can you break this closed system? Any idea? I think you have all been toward. How does the urine drains from catheter into the bag? By gravity. So by that rule, the bag should always be placed at a lower height from the patient. If during transportation, the person who is transporting the patient on a stretcher takes the urobag and places the bag on the level of the patient, what will happen? There will be retrograde flow of urine from the bag into the catheter, and this bag is collecting the urine. And I think you have already understood by now, urine is a very good culture medium. So whenever the urine is collected, organisms will grow. And if there is a retrograde flow, what will happen? the organism will enter into the catheter, and thereafter it will cause intraluminal infections. Understood? Again, catheter may be placed depending on the requirement. Catheters may be short term, may be long term. For example, say a patient is undergoing a surgery, say a laparoscopic surgery. It's a 1-day procedure. You need to monitor the urine output, and during the operative maneuver, you have put the catheter, you have performed the surgery, post operatively you have monitored the patient with urine output, etc. After 2 days, the patient is well, can walk on his or her own, and then what will you do? You will remove the catheter because the patient is able to go to bathroom by himself or herself. So that would be a short-term catheter. What are long-term catheters? Suppose a patient has a debilitated disease, patient has a neurological disease, has no control over the bladder, or the patient is admitted in the ICU for a prolonged period of time. For in those case scenarios, we need to put the catheter for a prolonged period. That means 15 days or more, 30 days, sometimes even more. Now it is obvious, the longer you keep the foreign body in the body, the higher the chances it will get infected. And based on that, the organisms that are recovered will also be different. So we have some particular set of organisms which will be causing infections in short term, and some organisms which will be acquired when the catheter is kept for a prolonged period of time. The commonly, I think you have understood that E.coli, Klebsiella, Pseudomonas, these are very commonly acquired and they can cause infections even in short catheter space for a short time. However, organisms like Proteus, Morganella and Providentia, these infections commonly seen in long-term placed catheters. Now, I have already told you about the extraluminal and intraluminal spread. Furthermore, other important factor can be urethral pressure and incomplete emptying. Now, these two factors can be seen because of any sort of medical condition. For example, there could be a neurological problem by either a neural problem or an intra-abdominal problem by which the bladder may not be emptied thoroughly. If there is residual urine in the bladder, the chances of infection in the bladder will also increase. Now, what are the risk factors? The risk factors can be divided into 3 parts. The first is device related, the kind of device that you are using, the patient in which you are putting up the catheter, and the caregiver related risk factor. That means what problems the healthcare worker might be doing which may lead to infections. First is device related infection. I have already told you, the longer you place, the more chances of infection are higher. So, duration of catheterization, and then the material by which the catheter is made. Catheters can be made of polyurethane or silicone, various types of materials are there, and it has been seen that silicone catheters are less prone to get infected. Hence, long-term catheters are generally made with silicone catheters. Patient-related risk factor would include first, female gender. Why? Because the female urethra is more commonly associated with genital and rectal region. Hence, chances of extraluminal acquiring infection are higher. Then, any kind of illness which alters the nutritive capacity of the body. When the nutrition is altered, the ability to defend against any sort of infection will decrease. So, patients admitted in the critical care units, or say patients having malignancies for chemotherapy, they have a higher chance of getting infected. Other risk factor would include old age, diabetes mellitus, and the last but very importantly, incontinence, fecal incontinence or urinary incontinence. When there is incontinence, that means there is gross contamination of the genital region. Hence, the chances of infection will be even higher. Coming to the caregiver related risk factor, look at this. Failure in adherence to aseptic techniques during insertion and maintenance. Keep these words in mind very carefully. That means whenever we are placing a catheter, we have to follow some particular set of particular procedure which should be followed meticulously when during insertion and during maintenance. That means as long as the catheter is kept. If these procedures are not followed meticulously, then infections will occur. And finally, whether the catheter was placed in an emergent situation or not. Whenever any procedure is done in an emergent situation, the procedure is not aseptic. Hence, chances of getting infected is even higher. Now, for diagnosis, you need to take the urine for sample to get send it to the lab for microscopy and culture. Now, how to collect the urine sample in these patients? Normally, till now, you have read that you will be sending midstream urine. But if catheter is placed, how will you take the sample? Anything else? This is the catheter, this is the urobag. How will you take the sample? Sampling port. Jodi na thake, suppose there is no sampling port in the catheter, old design catheter. Because this is very important. First, what you should not do, never take the sample from the urobag. Never. And this is probably the most frequently thing that may be done. Never take from the urobag. Also, never detach the catheter from the urobag tube and collect the sample. Why? Because all these surfaces are touched and they are all contaminated. You will end up getting an organism which is not at all causing the urinary tract infection, rather something else. What you need to do is, first you need to block this catheter tube. What will happen when you block this catheter? See, the urine is coming from the bladder continuously, drop by drop. So when you will blocking this catheter tube, there will be a column of urine in the catheter itself. Then look for the sampling port. If the sampling port is present, clean the hub of the sampling port with alcohol. Then take a syringe with a needle, insert the needle in the sampling port, and then take the urine sample. That is, after some time there will be a column of urine in the catheter itself, then take the sample. Sometimes you may see a catheter which does not have a sampling port. In that scenario, what you need to do is, after blocking the catheter over here, then clean the tube with alcohol and insert the needle in the tube and then take the sample. Objective is to take the urine that is present in the bladder, not from the urobag. Okay, that is very, very important. Now, the clinical for diagnosis of catheter-associated UTI, you have clinical criteria and a laboratory criteria. The clinical criteria is presence of at least one of the signs and symptoms of UTI, that is either fever, suprapubic tenderness, or like costovertebral angle pain, urinary urgency, frequency, or dysuria. If these are present, that is important. Now tell me, if a patient is already catheterized, how can the patient complain of dysuria or frequency? বোঝা গেছে প্রশ্নটা? পেশেন্টের ক্যাথেটার অলরেডি আছে, তাহলে ইউরিন তো বেরিয়ে যাচ্ছে, তাহলে পেশেন্ট কি করে বলছে যে বারবার পেচ্ছাপ পেচ্ছাপ তো হয়ে যাচ্ছে? বলতে পারে? যার ক্যাথেটার নেই, ফ্রিকোয়েন্সিটা হয় কেন? Why does the frequency of urine occurs? Because of the infection, there is irritation of the inner bladder wall, and that gives the feeling of micturition. And because it occurs repeatedly, the patient says there is frequent urge to urinate. But if the catheter is placed in situ, will that symptom be present? Then why these are kept over here? The reason is many a times you will find patients admitted for say a different illness and the catheter was placed say for about 4 to 5 days. Then the catheter was removed. After then the patient comes with symptoms of UTI. That will also be considered as catheter-associated UTI. বোঝা গেছে? পেশেন্ট অ্যাডমিটেড ছিল 4 দিন ক্যাথারাইজ ছিল, 5th ডেতে ডিসচার্জ করা হলো, 6th ডেতে আবার ফিরে এলো, এসে বলছে পেচ্ছাপ করতে গেলে জ্বালা করছে। দ্যাট ইজ স্টিল catheter-associated UTI because the symptom is present within 48 hours. তার মানে ইনসাকশনের পরে 48 hours হয়ে গেছে আর ক্যাথেটার বার করার পরে 48 hours হয়নি। দ্যাট ইজ দ্য ইনফেকশন উইন্ডো পিরিয়ড। If the patient is already catheterized, obviously he or she will not complain of dysuria or urgency. The complaint would be fever, suprapubic pain, sometimes referred pain in the costovertebral angle. Coming to the laboratory criteria, we have 2 important criteria. If the patient is asymptomatic, then a colony count of more than 10 to the power 5 is significant. But if the patient is symptomatic, any count more than 10 to the power 3 is significant. Treatment is very simple. Most importantly, you have to remove the foreign body because the foreign body gives access to the microorganisms. Next, you need to give proper antimicrobial therapy based on the culture report. For asymptomatic bacteria, treatment is indicated in some scenarios like pregnancy or any prior to any urological procedures. If you remember these two, then fine. Okay. Only in these 2 case scenario, antibiotic therapy is recommended in case of asymptomatic bacteria. Coming to the next topic is catheter-related bloodstream infection. Now, what are these catheter? What catheter? আগেটা তো বললাম ইউরিনারি ক্যাথেটার, আর কি কি ক্যাথেটার হয়? Central line catheter. What is a central line catheter? There is 2 terminology. First is you have to understand what a central line is. So any bloodstream infection which occurs when the source is due to the central line itself, we call it as central line related bloodstream infection or catheter related bloodstream infections. There is one more terminology which I will cover later on. It is called as CLABSI, central line associated bloodstream infection. Now this definition is used for surveillance purpose. There is a clinical diagnosis and there is for surveillance. So don't get confused in between. For clinical diagnosis, the terminology is CRBSI, catheter related bloodstream infection. Now, what a catheter is? This is a catheter which terminates in the great vessels or the central vessels, and they are called central. There are many types of central line. It could be placed in the jugular. There are many types. It could be tunnel, could be non-tunnel, could be peripherally inserted. There are various types. Now, why these are required? Obviously, especially in patients which are very severe or critically ill, we need to monitor various parameters of the body like unilateral blood pressures, or we have to give some drugs which are very like noradrenaline. This sort of drug we need to give directly into the central line for better efficacy. Or say we need to give what is called as TPN, that is total parenteral nutrition, or say some drugs which are very viscid If we give this drug to the peripheral veins, obviously the veins will get thrombosed. So for all many scenarios, we need to place the catheter. Now, depending on the type of the catheter, the most important part is in which location the entry site is and how distant are these catheter from the vessel to the skin will depend the propensity to cause infections. For example, if I place a catheter in the jugular vein in one patient and in another patient I place a catheter in the femoral vein, which catheter is more likely to get infected? Why? No, because it is more close to the groin will have more microorganisms and hence the chances of infection is more common. Similarly, if we place a tunnel catheter, what will happen? The chances of infection will get reduced. Now, like in case of urinary tract, so this is a pictorial diagram which shows a catheter that has been placed into the great vessel, that is the great veins. Now, how does the infection occurs in this case of catheters? The first type would be that is extraluminal and intraluminal. Now, intraluminal means through the catheter. So, whatever drugs, medications, fluids I am giving, if that is contaminated, that will be through that route. Extraluminally, it may come from the skin or from the hands of the healthcare workers. The organism will get colonized on the extraluminal surface of the catheter and the entry site. From there on, it will travel extraluminally and into the vessels, causing bloodstream infection or as also called as sepsis. Similar to urinary catheter, we have some risk factors related to device, related to the patient and related to the care group. Over here, the device related would be first important part, like in urinary catheter, it will be the duration of the catheter, placement of the catheter. The longer the catheter is placed, the chances of getting infected is higher. What is the site? Based on the probable of contamination, femoral or jugular. The catheter type, non-tunnel catheter are at a higher risk. That means tunnel catheter would be better. Then number of lumens. Why number of lumens? If you have seen the central line catheter, there will be 3 lumens. Every lumen is dedicated for some sort of medication. One for say taking out the blood sample for testing, one for particular set of drugs, and one for say TPN. Now, whenever there are multiple ports, during handling of the catheter, the handling will be more messy. And if the number of ports are more, the chances of infection also increases. Further, insertion circumstances. Again, if the central line was placed in an emergent condition, that means aseptic procedures may not have been followed, hence chances of infection has increased. Now moving on, the patient related, obviously almost the same patient related parameters. Most importantly, like urinary catheter in caregivers, first is poor hand hygiene, not able to follow the aseptic procedures during insertion and maintenance. And finally, I think you have seen the ports of the central line. So those ports are operated, and every time those ports are used, the hubs has to be cleaned with alcohol. If those proper cleaning procedures are not maintained, infection can occur. Now, again, based on the type of the intraluminal or extraluminal, various organisms are also different. This is very simple. For extraluminal, that means the organism is coming from the skin of the patient or from the hands of the healthcare workers. So commonly those would include Staphylococcus either cons or aureus. However, if intraluminal, because of contaminating of the hub of the ports or the drugs or the medication, then we can get infections caused by hospital gram-negative organisms present in the hospital like E.coli, Klebsiella, Enterobacter, Pseudomonas, etc. Next comes how to diagnose. The first would be the clinical criteria, that means based on the patient's signs and symptoms. What are the signs and symptoms? the patient will have fever, chill, rigor, and hypotension. Many a times the patient will be already on say adrenergic drugs. In that case scenario, the requirement of the adrenergic drugs may increase. That is also a kind of hypertension, or the overtly hypotension যদি থাকে তাহলে হতে পারে. Next, we have signs of inflammation on the port site. The site where the catheter is inserted, that is called as the port site. What would be the signs of inflammation? It will turn red in color, inflamed. There will be signs of erythema, and sometimes even serous fluid may come out. That means the site has been. For microbiology criteria, this is very important. Simultaneous blood culture from central line and peripheral line is carried out, and the central line culture bottle flags 2 hours earlier to peripheral blood culture line. This is also called as differential time to positivity. Let me explain this. Patient is having bloodstream infection, right? It may be due to the central line or may be due to other cause. Okay. Now you tell me, suppose I take 2 blood samples, one from the central line, that is through the central line port, and say from the left arm, that is the peripheral line. I take the blood sample simultaneously, I put in culture bottle and send it for culture. Now what the machine will tell me? It will tell me when the culture comes positive. Okay. Now let me tell you the first scenario. Say in scenario number 1, both the bottles that has been sent flags positive, say at 4 hours after incubation. Both the central and peripheral. Suppose this is the central line which is infected, and it drains into the blood vessels with the heart, right? There might be 2 scenarios. First scenario is the central line is infected, and from there the organism is spreading throughout the body, or the infection is elsewhere in the body, and we are getting the organism both from central line and peripheral. এই দুটো কেস সিনারিও তো হতে পারে, তাহলে ডিফারেন্সিয়েট করবো কি? ফার্স্ট কেস সিনারিও যেটা এখানে বললাম, ভাবো সাপোজ দিস পেশেন্ট হ্যাজ an abscess in the abdomen. The source would be from the abscess, so the organism will go from the abscess site into the blood similarly. So if I take a blood sample from the central line and from the peripheral line, the number of organisms that is obtained will be almost similar. If the number of organisms are almost similar, the time to reproduce and flag positive in the machine would be almost similar. So we will get both the bottles flagging positive almost at a similar time. এটা বোঝা গেছে? Now suppose if the central line is infected, then the number of organisms in the central line itself will be very high as compared to the organisms present in the blood. So if I take a blood sample from the central line, the number of organisms will be higher as compared to the blood sample taken from the, say, a peripheral vein. Now if the initial number of organisms is higher, the time to flag positive will also reduce. So in this case scenario, we'll have this, suppose a central line, blood from the central line will flag positive in, say, within 2 hours, but the peripheral line will come positive at 4 hours. This is called as the differential time to positivity. Why this is used? We are using automated blood culture system. This automated blood culture system will flag positive when a critical number of bacteria goes within the bottle. The longer time it takes to Flag positive, that means initially the number of organisms are less. If the initial number of organisms are higher, the time to flag positive will get reduced. So in this case scenario, what will happen? Because the number of organisms is higher in the central line, so the blood sample taken from the central line side will have higher number of organisms as compared to the blood sample taken from the peripheral line. Hence, the bottle in which the blood from central line is placed will flag positive earlier than the peripheral line. What is the cutoff time? The cutoff time is at least 2 hours. It may be 3 hours, it may be say 4 hours, whatever may be the time. Okay, that is called as the differential time to positive. However, please remember the caveat. Both the organisms must be the same organism. If they are different, this is not a case of central line. Now have you understood? তাহলে ওয়ার্ডে বা আইসিইউতে যদি কোনো পেশেন্টের CRBSI ডায়াগনোসিস করতে হয় তাহলে ব্লাড স্যাম্পল নিতে হবে অ্যাটলিস্ট দুটো বোতল simultaneously at the same point of time, one from the central line, one from the peripheral line. শুধু একটা ব্লাড স্যাম্পল পাঠালে কোনো ডায়াগনোসিস হবে। এটা এখন থেকে বলে রাখছি, পরে যখন ইন্টার্নশিপে কাজ করবে এই ব্লান্ডারগুলো যেন পরে না হয়। আচ্ছা, ইনফেকশন কন্ট্রোল প্রসেসগুলো পরে আসবে। ট্রিটমেন্ট ইজ সিমিলার টু দ্যাট অফ যেটা হচ্ছে অ্যান্টিমাইক্রোবিয়াল থেরাপি দিতে হবে। ব্যাকটেরিয়াল ইনফেকশন তো অ্যান্টিব্যাকটেরিয়াল ড্রাগ দিতে হবে। আনাদার ইজ কল্ড অ্যাজ অ্যান্টিবায়োটিক লক থেরাপি, সেটা আমি পরে বলবো। এখন আর একটা কভার করবো, তারপর বাকিটা পোস্ট লাঞ্চ। ঠিক আছে, জাস্ট ওয়েট। দ্যাট ইজ ভেন্টিলেটর অ্যাসোসিয়েটেড নিউমোনিয়া অ্যান্ড অলসো নাও কল্ড অ্যাজ ভেন্টিলেটর অ্যাসোসিয়েটেড ইভেন্টস। নাও হোয়াট ইজ আ ভেন্টিলেটর? দেখেছো কি ভেন্টিলেটর কি কাজ করে? What is the function of ventilator? Why it is required? Just a general idea. I'm not going to specific. Many clinical conditions in which the patient is not able to breathe in the appropriate amount of air. Maybe the breathing is present, we need to increase the effort, or the patient is not breathing at all. Then we have to put the patient on ventilator. Now, how these ventilators are placed? Any idea? কিভাবে? The most common method is called as the endotracheal tube. The other would be a tracheal tube, in which tracheostomy is made and a tracheal tube is placed. Endotracheal means it is a tube which is placed from the mouth, and the other end of the tube will be into the trachea, and the end that comes out from the mouth is attached with the ventilator. This is called as the endotracheal tube. Now, this is a very common type of infection that occurs in critically ill patients. Now, this is again divided into two types. The first is called the early onset VAP, and the second is called the late onset. Now, early onset is the kind of pneumonia which occurs within 4 days after placement of ventilator, and late would be that is more than 5 days. Now, early onset, the organisms are commonly caused by organism causing community infections, whereas the late onset are commonly caused by organisms which are present in the hospital itself. Now, when we say endogenous and exogenous, again, endogenous means patient's own flora, and exogenous means patient that is present in the environment. Now, this is the picture in which endotracheal intubation is done. Now, look at this. There are some parts of the endotracheal tube. The first part is the tube itself. One end is in the trachea. The other end would be connected to the ventilator itself. This is a balloon in which air is pushed and the balloon opens over here. It gets inflated and it keeps the endotracheal tube in place. Otherwise, what will happen? Every time the patient deglutes, the tube will come out. It is also called as extubation. Now, the patient is lying supine. If this is occluded by the balloon, what will happen to all the secretions? It will get collected over the balloon. Now, these secretions has to be taken out. For that, we have a tube for suction. So, this is the normal part of an endotracheal tube. Now, from where does the patient acquire the microorganisms causing infections? Any idea? First, the oral cavity of the patient have many microorganisms. Oral cavity and the pharynx, oropharynx, all these organisms may get collected in this region that is above the balloon, and these secretions will have patient's own organism. If this balloon is displaced or the endotracheal tube is displaced, what will happen? This secretion will go into the respiratory tract and cause infection, that is end up with pneumonia. Alternatively, sometimes, now what is behind the trachea? It's esophagus. Esophagus আছে তাতেও doubt আছে. Okay. Now most of the critically ill patients will be placed supine and they are on PPIs, that is proton pump inhibitors. Now what is the role of proton pump inhibitor? It reduces the gastric acidity. Now why that are used? Whenever the patient is under very critical illness or you are pushing the endotracheal tube, these all produce tremendous amount of stress in the patient's body. Now this stress can cause stress ulcer in the stomach. To prevent that, proton pump inhibitors are used. The adverse effect of using the proton pump inhibitor is that gastric acidity is lower and then the patient is again placed in supine positions. What will happen? The microorganisms within the small intestine will slowly come up, and now because there is no acidity, they will even reach the stomach, and from the esophagus it may come out from the glottis into this subglottic space. So the other source of organism would be patient's own intestine. So one source would be the oral cavity and the other would be patient's own intestine. The third source would be the ventilator itself, because the ventilator is sucking the air and then pushing it into the lungs. Now if that air is already contaminated, then it can cause infection. And how does that air get contaminated? Normally, do we expect bacteria to be present in air? শুনেছো bacterial infection from air? Mostly are viral. তাহলে আসে কোত্থেকে? Because the ventilator has what is called as humidifier. Normal air যদি লাংসে পুশ করা কি হবে? The air will be very dry and it will dry out all the respiratory tract. So we need to maintain the humidity. Normally আমাদের paranasal sinusের কাজটা কি? Humidify the air. But we are all bypassing that. So we need to humidify. Now the humidify কি দিয়ে করা হয়? Water দিয়ে. Now if that water has bacteria, what will happen? The ventilator will pump all those bacteria directly into the lungs. Now what are these types of organisms? These are commonly aerobic organisms like Acinetobacter, Pseudomonas. Hence you will see VAP by Acinetobacter pseudomonas very commonly in the ICU. And last but not the least, whether we need to connect the ventilator or disconnect the ventilator, or we need to go for suction of the secretion, we are manipulating the tube with our hands. So if the hands of the healthcare workers have organisms, they can travel extraluminally into the respiratory tract. So these are the sources of bacteria causing ventilator associated pneumonia or events. Okay, তাহলে কি কি হলো? One is endogenous, other would be exogenous. Endogenous would be the oral cavity and the intestinal flora. Exogenous could be the ventilator itself or from the healthcare workers. So the first part would be colonization of the organism on the ET tube itself. Then after colonization, it will form biofilm, and then it will progress further, causing infections. Now, the risk factors would include these following risk factors. First is sedation. Now, why sedation is important? বেশি হয়ে যাচ্ছে নাকি? আরে গলায় জল খেতে গিয়ে অল্প জল গলায় পড়ে গেলে লোকে কাশতে শুরু করবে, আর তুমি একটা আস্ত টিউব ঢুকিয়ে রেখেছো, পেশেন্ট তো রিয়াক্ট করবে। সেই পেশেন্ট যদি রিয়াক্ট না করে তাহলে তোমাকে কী করতে হবে? মাসেলকে রিল্যাক্স করতে হবে। ফর দ্যাট ইউ নিড বোথ সিডেশন অ্যান্ড মাসেল রিল্যাকশন। অ্যান্ড হোয়েন এভার ইউ সিডেটিং দ্য পেশেন্ট, তাহলে কি রিফ্লেক্সগুলো কমে যাবে, রিফ্লেক্স কমে গেলে ইনফেকশনের চান্স বাড়বে। নেক্সট ইজ সুপাইন পজিশন। পেশেন্ট যদি ফ্ল্যাট সুপাইন থাকে তাহলে কি বললাম, সিক্রিশন অ্যাসপিরেট করার চান্স থাকবে। নেজোগ্যাস্ট্রিক টিউব, কমনলি এন্ডোট্রাকিয়াল ইন্টুবেটেড পেশেন্ট যদি ইন্টুবেটেড থাকে দেখবে একটা নেজোগ্যাস্ট্রিক টিউব পড়ানো থাকে, যেটাকে কমনলি বলে রাইস টিউব। কেন পড়ানো থাকে? দ্যাট ইজ ফাইন ফর এন্টারাল ফিডিং। অ্যানাদার ভেরি ইম্পর্টেন্ট পার্ট ইজ যখনই সে আম্বু ব্যাগ করা হয় বা ইন্টুবেট করা হয়, we push the air through the mouth, so some of the air gets entered into the stomach through the esophagus. ওটাকে ডিকম্প্রেস করতে হয় immediately, hence both for feeding and other purposes. This nasogastric tube, এটা যদি esophagus-এর মধ্যে থাকে তাহলে কি হবে? What will happen to the esophageal sphincter? Sphincter will get dilated. If the sphincter gets dilated, there will be regurgitation from the stomach contents, তাহলে intestinal bacteria access পাবে। Third is obviously critically ill means body's immunity is not working. Critically ill patients, you will find low neutrophils, low lymphocytes. That means if the organism reaches into the air sacs, it will ultimately cause infection. And finally, I have already told you about stress ulcer prophylaxis. Similar to the previous, we have some device related and then patient related and healthcare related. Just go through these points. Device related, I have already told you the duration is very important, how long the ventilation is kept, then whether nasogastric tube is present or not, what is the pressure in which the ventilator is pushing the air. If we are using very high pressure, the chances of infection will be even more. What are the other factors like whether tracheostomy is done or not, and if it is done, it's a planned surgery or an emergent surgery. Emergent will be more prone to infections. Patient status, and we have healthcare personnel related. That means always remember the hands. Now coming to diagnosis of ventilator associated pneumonia. Now here comes the important part. Earlier it was called as pneumonia, now ventilator associated events. Any idea why this name change is suggested? What is pneumonia? Pneumonia is a constellation of signs and symptoms, but in ventilated patients, all signs and symptoms may not be present every time. So by definition, you may not complete all the criteria of being it a pneumonia. Hence, it is called as ventilator associated events. Now, I will not go into the specificity of all these things, but I will show you this chart. This is called as the modified clinical pulmonary infection score or CPIA score. This score is used for diagnosis of ventilator associated events. মুখস্থ করার দরকার নেই, try to understand what it entails. First is Whenever there is an infection, you may find either hypothermia or hyperthermia based on the patient status. Temperature may rise, and if the patient is very ill, patient may even body may even cool down. That is hypo or hypothermia. Similarly, peripheral blood count. Normal reaction is increase in leukocytes, but sometimes in severe cases decrease in leukocytes. Then what are the tracheal secretions, whether it's purulent or not. Oxygen requirement, that is, if there is an inflammatory process going on in the regions where blood oxygen exchange is occurring, what will happen to the oxygen saturation? It will decrease. To compensate, you need to increase the partial pressure of oxygen. That is also called as the FiO2 requirement. So if an infective process is ongoing, FiO2 requirement will increase. Next, I think you already know, in pneumonia there will be radiological changes. কি পাওয়া যায় radiological change? Consolidation পাওয়া যায়। Consolidation থাকতেও পারে নাও থাকতে পারে। এবার এটা ইনফিলট্রেট হতে পারে or diffuse হতে পারে। And finally, you take the tracheal aspirate and do the culture. If the organism is there with heavy growth, it is highly suggestive of pneumonia. So based on this scoring criteria, we may ascertain whether the patient is having ventilator-associated pneumonia or not. So for laboratory diagnosis, what are the important part? That would be blood counts and culture of the tracheal secretion. Microscopy and culture of the tracheal secretion. These are the two important. Radiologically, we need to take the chest radiograph. So specimen would be either endotracheal aspirate or bronchoalveolar lavage. What is bronchoalveolar lavage? What is tracheal aspirate and what is bronchoalveolar lavage? Tracheal aspirate means I put a suction catheter in the endotracheal tube, pass it through the tube, and then take the secretion by aspiration. Right? If this secretion has microorganisms with inflammatory process, then from microscopy and culture we can ascertain that this is the infective pathogen. Alternatively, if we do have the setup, we can go for what is called as bronchoalveolar lavage. What is bronchoalveolar lavage? Suppose this is the part of the lung which is affected. After bronchoscopy, we will push the bronchoscope over here, flush the area with normal saline, and then re-aspirate the normal saline. So if the organism is causing pathology over here, the organism will come out in the bronchoalveolar lavage. There are specific set of criteria, that is 10 to the power 5 colony forming units for endotracheal aspirate, or 10 to the power 3 for bronchoalveolar lavage, or 10 to the power 4 for bronchoalveolar lavage, or 10 to the power 3 for protected bronchial sampling. এখন তাহলে এতটাই থাক। Post lunch we'll start with surgical site infection. So out of the 4 important infective conditions, I have covered 3. Next we'll look at the surgical site infections, and we'll also look at how we can adopt some policies and procedure to prevent these infections in the hospital. Okay.